be pushing a lawnmower, and all of a sudden I'm going down a hill, and then I go up a hill. As I'm going up that hill and I'm pushing that lawnmower, I need more extension, and then I need more flexion. The word more came out of my mouth. And when you need more extension and flexion between the two that you're going to use, Jonathan, we know what's going to kick in. We know the extensors are going to kick in. As soon as those extensors kick in to brace, I'm no longer using an accessory muscle. I'm using accessory muscle for primary activity. My ribs are going to what, everybody? Pop up. They're going to brace. What's the best bracer and stabilizer of my lower spine? What?
The lats.
Good answer. Wasn't the one I was looking for, though. I like it. How about this one? She said the lats. What's the best anterior stabilizer of your lower spine? What? The crura. What is the crura attached to? Where does it come from? We talked about this yesterday, didn't we? How the diaphragm and the lats kind of have an affair going on. The diaphragm's now kicking in. And when the diaphragm kicks in, it becomes now a muscle of what? Stabilization. Rick, now I know respiration from it. Some, not much. What's going to pick up as I push that lawnmower? Scalenes. Now they're my primary what? Muscles for respiration. They're helping me get air in. They're really helping me get air in by lifting a carapace to give you freedom to move your lung. Because the posterior mediastinum, Sonia, is squashed. You can't get air back there. Now I got this front. It almost looks like you have COPD. You're short of breath. And that's what, because these scalenes took over. Person that can go up and down those hills pushing that lawnmower without using their crura and their lat for stability, because they have glutes and hamstrings and abs, don't have to count on these scalenes. When you do a scalenectomy, you might as well do an abdectomy, because the scalenes are your new abs. And if you cut the scalenes, you're really in hot water. Now what are you going to use? I know a guy coming up on the block that you're going to use that goes from the sternum up to the occiput. And a lot of people have cut off scalenes because they twist themselves, and now they use SCMs. They don't cut them off, they're there, but they shut them off because they twist. And now they got a new person on the block to help them do, what's the word that we just circled 3 times? To help you raise the carapace. To help you raise it. So raise. And that's what they look like. And this is a lady who's, she's just inhaling with them and exhaling with them. And inhaling with them and exhaling with them. She raises, she lowers. She concentrically moves, she eccentrically moves. At the same time, Tyler, her back is extended. Do you have a question, Kurt? No? Subclavius. Big muscle with a big message. Little message. It should be a little muscle with a little message. Subclavius goes between the first rib and the clavicle. Okay. In this course, it's a big muscle. It draws the shoulders down. Draws the shoulders down. It draws the shoulders down because it attaches to your collarbone. It pulls the collarbone down because it raises the first rib up. If you want to write down raises the first rib up, raises the first rib up, write it down because someone forgot to write that down. I would have wrote that down. Raises the first rib up. Draws the collarbone what? Down. They become very tight on the right side because first ribs are being pulled up, Tyler, by what muscle? Scalenes. So if the first rib is being pulled up by the scalenes, what muscle then becomes short and tight and active in that short and tight position? The subclavius. And now my ability to really get this expansion from a collarbone that's married to this little first rib could be limited if I do not keep the subclavius longer. So you have a technique in your manual that's the subclavius technique. The subclavius technique maximizes the range of the subclavius muscle. The subclavius technique inhibits scalene function. The subclavius technique allows your rib cage to rotate. What's the rib that generates movement on that thorax? What rib generates all other rib function? What will the research tell you that directs the rotational direction you're going down in the highway of rib activity? What rib directs all rib function? Rib number 1. Rib number 1 needs to move away from that clavius, that clavicle. If rib number 1 doesn't move from the clavicle and rib 4, 5, 6, 8 do, we got a problem. We call that a superior T4 syndrome. Top ribs move, bottom ones don't. Top ribs don't move, bottom ones do. Something's limiting my airflow patterning, and we will go over that this afternoon, maybe even yet this morning. Subclavius activity. We need subclavius length on the right side. We need this right subclavius muscle to allow that collarbone to externally rotate while the rib below it internally rotates. If the rib above it is pulled up into external rotation because you're trying to get air into your chest wall, and the ribs below it are going into internal rotation because that's the direction you're positioning yourself in, you have no need to do anything with the posterior mediastinum because I'm getting enough air in my body on the right side with hyperactive scalenes, hyperactive pecs, hyperactive SCM, and hyperactive subclavius. The subclavius is the little guy that's kind of like the Monopoly board. You have two. You have Boardwalk, and what's the other blue one, the purple one? Park Place. Can you say SCM and subclavius? They control the board. You land on them twice, they wipe you out, you're done. Game's over. 3 shots, you're out. Every time you roll that die, you get a little nervous. I might land on them. These guys control your board. They control you. I spent a few years on the subclavius. This is a good friend of mine, Dr. Stan Harn at the dental college. He's an oral professor of anatomy, teaches dental students. And I got to know him in my first year of dental college, and I love him for a lot of reasons, but he always lets me, back then I was using his cadavers. And we did this little study on these cadavers and found that subclaviuses are very, very hypertrophied on the right side on humans. So here's a picture of picture of an individual that has a collarbone and a first rib, and you can see this is the first rib attachment site. Collarbone is right on top of it, first rib collarbone, and you can see the size of the head of the collarbone on this side, and then I'm going to show you the other side. Look at the size of this one. These are all this activity is the first rib and the collarbone. All this activity in here results in hypertrophied bone growth of bone because of shear, torque, and twist. You know what Osgood Slaughters is. Osgood Slaughters is where bone develops because there's pull on it. You have the same thing going on in this side of your chest wall. Collarbone attachment sites get big. First rib attachment sites get big. Second rib attachment sites get big compared to the what? The other side. So the first rib and the first rib head and the clavicles attachment site becomes hypertrophied. And here's one example of it. And you can see again the size of this rib head, and look at the size of that one. And when you pull it apart, they're all that way. They're all overdeveloped on that right side. So there's your first rib head. This is costochondral ligament. It's really hard to show slides on PowerPoint because they never are really very clear. And the orientation is always tough. But here's your manubrium. There's your first rib. There's the subclavius. And this is hypertrophy bone. Very, very rigid, turgor type of bone. It's tough to move. Levator scapulas, they elevate, they rotate. Can you circle the word elevation on page 11? All this is going to have a meaning later on in the course. They elevate and raise, elevate and raise, elevate and raise, elevate and raise. They rotate the scapula. The levator scapula also can be fixated by the levator. It can extend it. When it's fixed, it can become, the scapula extends. It side bends the neck. Goes from the transverse, it comes or goes from the transverse process of C1 through C4, and then it comes up and goes to or comes from the scapula, spine, medial border of the scapula. It's a twister. It's a twister. It turns you. It's meant to stay turned. When this muscle becomes straight, Chris, the gal that we were looking at this morning where the shoulder blade was forward, that muscle was untwisted. And when it's untwisted, it becomes an elevator. So why don't you write this down? The levator scapula, untwisted levator scapulas, are like scalenes, are like sternocleidomastoids, are like subclaviuses. Why? Because in an untwisted position, they are elevators. They raise. So obviously, if I want to get raising out of my scapula, I would bring my shoulder blade, scapula, and blade forward, which untwists it and makes the Sonia a better elevator. So now I've got lots of good elevators over here because my shoulder blade has 4 groups right off the bat that's raising it up. And I'm going to get a lot more mileage out of that levator scapula if I bring my arm forward. So Susan, when you said her shoulder looks forward, I didn't want to tax you too bad. I would want to ask you, why do you think that brain on her left side wants her right shoulder blade forward? And if you would have said, because it gives her a mechanical advantage to raise the shoulder, my jaw would have dropped.
Mine too.
It would have dropped. But we forget that we bring our shoulder